Good evening, everybody, and welcome to another edition of the USI Smart Learning Program. Today, we have topics related to andrology, which are very important topics. They are practical case-based discussions which are being done by two very young academic andrologists, Dr. Pramod and Dr. Karthikeyan. They are very interested only in andrology, doing good andrology work now, and both of them are academically oriented also. So I presume all the residents who logged in would be benefited with that. We are dealing with adolescent varicocele, undescended testes, and azoospermia. These are all topics which you may not get as a case, but they are all important for your practice and for the theory point of view. So I would uh, request all of you to be tuned in, and it could be interactive. You could put your questions on chat box and have an interactive discussion. With this remarks, I would now invite Dr. Arun Chawla, Chairman, Indian School of Urology, to give his opening remarks. Over to you, Dr. Arun.
Yeah, thank you, Dr. Keshav, and good evening, everyone. It's a great pleasure in introducing our two young faculty who are our not only colleagues, but I think have made a lot of contribution in the andrology subspecialty of our USI. So we have today, as Dr. Keshav mentioned, two faculty who will be covering the important topics on andrology. What we have done is, when we were getting the messages that probably we are going for exams and we are a little bit of need exposure in few cases related to andrology and female urology, so we have introduced this session especially for the exam going students to cover the important topics. A few of these topics may come as a short case or ward rounds, and these will be deliberated by Dr. Pramod and Dr. Karthikeyan, who have carried these topics in our previous webinars related to andrology. So just to quickly introduce, Dr. Karthikeyan is a renowned andrologist and urologist, and in Apollo Hospital, Chennai. He is has honor of having a clinical fellowship with Dr. Vineet Mothra and observership at Miller School of Medicine. He has a diploma in male infertility. He is a convener of USI Andrology subsection and is a member of USI Collaborative Research Panel. He is a member of Global Andrology Forum, American Center of Reproductive Medicine, Cleveland Clinic, USA. If you can recall, during the COVID times, he was very active in all the andrology webinars that we had under the ages of ISU USI. With him joining is another young dynamic faculty with a keen interest in andrology. He is working as a consultant andrologist in NU Hospital, Bengaluru. He is also a visiting tutor at University of Edinburgh. He has done again a few fellowships related to andrology. One, he did a penile implant fellowship in Madrid, and then he had a European urology fellowship in penile reconstruction in Belgrade. He was a visiting andrology fellow under Professor Niederberger at the University of Illinois at Chicago. Both the young faculty have a number of publications under their name and have a contribution in writing the book chapters. With this, I'll not waste much time. A request to all the writers to post their question in the chat box, and those of you who have those who, if you have any particular question, they can unmute and ask the questions at the end of the presentation. This webinar has been split into 4 subsections. 2 will be covered by Dr. Pramod and 2 will be covered by Karthikeyan. And I request you, because they have worked very hard in making these presentations, what you can say, tailored to your, what you can say, what you need. So please stay attentive, stay proactive, and I urge you to post your question in the chat box or just unmute and ask the question when he has finished his presentation. With this, hand over to Pramod and Dr. Karthikeyan to begin. Okay.
Thank you for your kind introduction, sir. So I will start the first presentation. Let me share my slides. So I'll begin with the adolescent varicocele presentation. So yes, this is one of the most controversial topics, both in the pediatric urology and in the andrology. So let me see how I can do my best.
Your slides are not visible yet, Pramod.
Okay, let me reshare it again. So is it visible now? Still no?
Yeah, it's
Yeah, it is
visible. You
visible.
can make it. Yeah, absolutely fine.
Okay. Okay. So like I said, still one of the most controversial topics. So let me begin. Let me see how best I can make you all understand. So keeping the residents in mind. So just to begin with a small case scenario, a 12-year-old guy who comes with a constant or a chronic dull aching right scrotal pain with no history of trauma. On examination, you feel that it is not any acute scrotum, there's no pain, but you feel a grade 2 varicocele on the right side. And ultrasound also is done, which shows a right grade 4 varicocele. So you see there's a discrepancy in the grading. Again, do not get confused. So there are different gradings. Grading is different on clinical examination where there are only 3 grades. And on ultrasound, there are 5 grades. So you can go through all this grading in detail later on. So basically what I wanted to make a point is that when you see grade 4, grade 5 on the ultrasound, yes, it is possible because it's a different grading on the ultrasound. So let's discuss a few theoretical aspects, and also meanwhile, we will also discuss the management options as well. So varicocele in prepubertal boys is just less than 1%. In the post-pubertal, it is around 5 to 30%. And whenever we discuss whether should we intervene, should we do a surgical intervention in these adolescent varicoceles or not, we come across these factors which usually prompt whether should we go ahead with the surgery or not. So residents, you need to remember all these points. Keep this as the standard points, and then you can go on explaining each of them. There is no easy answer to this. Nobody can say that yes, all adolescent varicoceles need surgery. But again, you cannot argue otherwise also. So you can always take each point and write the pros and cons in the theory examinations or during any short discussions, and accordingly you can take it forward. So let's take the first 2 points, which is basically an abnormal semen parameters should prompt a surgical consideration. So is it that easy to do a semen analysis in adolescents? Definitely not. If you see this paper, only 13% of the pediatric urologists asked for a semen analysis routinely in their practice when dealing with adolescent varicoceles. And out of these 13% who asked for semen test, 50% of them had some degree of discomfort discussing the semen analysis with the patients. And those who felt uncomfortable, the physicians who felt uncomfortable, they said, they cited reasons saying that ethical concerns, religious reasons, and the discomfort because of the presence of the parents itself. So there is quite uncomfortable feeling both for the patient, physician, and for the parent when we discuss semen analysis in adolescents. And again, the same study where you see here, when the patient and the parent comfort and willingness were evaluated. So if you see the patient column, the majority, that is the 27% of them, the patient said that they're very uncomfortable and they said they will not do the semen analysis. When you see the parent column, the majority, that is the 38% of them, the parents, they said that they do not know what a semen analysis is. So with such a data from advanced countries, so you can expect how difficult it is to ask for a semen analysis in our Indian patients. And also this is again a retrospective study from Asim Shukla sir, who is very active in the USI's pediatric urology programs. So they also said that many of them ultimately have normal serum parameters even without any intervention in these adolescent varicocele patients. Despite an initial poor semen analysis, they tend to become normal over a period of time. And we need to be careful not to overtreat these adolescent varicoceles. And again, the other biggest controversy is that what are the normal reference values for semen analysis in children? The adult semen analysis reference values were designed based on the data taken by the WHO, the data which it took from, I think, from 25 to 40-year age group couples, they took it, and then they made the reference values in adults. But in children, we do not know what is the normal semen parameters. So asking for a test in which we do not have a reference value is of no meaning. So deciding a surgical intervention just depending on a semen analysis is practically not possible. So moving on to the next one, which is the pain. 2 to 10% of the patients who have varicocele, yes, they do complain of pain. But if you do the varicocelectomy surgery on them, and yes, you see a complete resolution of pain in 52% of the patients, but there is still a big chunk of patients who may not completely benefit. Partial resolution may be seen in 41%, but yes, still they're not completely cured of pain. And so again, this is a paper which discusses about pain management, chronic orcalgia management in pediatric patients without any anatomical abnormality. That is, even without a varicocele, there are different ways to manage pain. Just because an adolescent has a chronic total pain and you incidentally find a varicocele, do not jump into suggesting a surgery. Try the simplest conservative measures first, like you ask them the bowel bladder history, ask them whether are they over distending their bladders, advise them the timed voiding, and so on. Try the conservative measures, treat their constipation if they have a chronic constipation, which could be one of the cause for their pelvic pain, in turn leading to a scrotal pain as well. And if required, also start some medications like simple paracetamol tablets or amitriptyline or a gabapentin. So there are different ways to manage a chronic orcalgia. Do not jump into suggesting a varicocele surgery in such groups. Again, so moving on to the other indication, wherein if the testicular volume difference is more than 15 or 20%, then again a surgery is indicated. That's again one of the indications that is mentioned. Yes, reports have, the studies have shown that once you do a microsurgical varicocelectomy in this adolescent varicoceles, the testicular catch-up growth happens. But there are other studies which contradict that. What others argue that is the catch-up growth that you see could be just the testicular edema because you have divided the lymphatic vessels during the varicocelectomy. So again, so do not base your treatment just only on the testicular volume differentials. So that's what I'm trying to say, that each point there is a pros and cons. So yes, you cannot give a straightforward answer in the theory exam or when you're asked in Viva, but try to take each of these points and write pros and cons, and accordingly, I think the examiner should be okay with your answers. And again, the next we discuss about the ultrasound finding of peak retrograde flow more than 38. The European radiologists, they themselves say that there is insufficient data to use this parameter, which is the reflex peak velocity, to determine the need for the varicocele repair, because there is no standardized protocol, and there is lack of consensus on how to do this, measure this peak reflux velocity, whether you measure it when the patient is sitting or standing, or when he's taking a deep breath or doing a Valsalva. So all these make a difference in the measurement of the peak reflux peak velocity. And also the angle correction is very much important in the Doppler, because it also depends on how we are holding the probe, whether it is at the 90 degree, 60, 30 degree, all this give an erroneous estimation of the reflux peak velocity. So they themselves admit, that the European Radiologist Association, that themselves say that it is not recommended to decide your varicocele repair based on this reflux peak velocity. Now, moving on to the next point, which is infertility. So this is again a study from United States, where they tried to follow varicocele patients, and what they found was 42% of the patients they were not able to follow. This is again in a country where they have good solid database, and they usually do good follow-up protocols and so on. So you see such poor follow-up rates when it comes to adolescent varicoceles. And also when they were asked, have any patients developed infertility, 89% of them, there was no data. Basically, there was, I don't know. So many of them, they said that they were unable to assess the infertility because they had no data, because they're unable to follow up the patients. And again, will the paternity rates change whether you do the varicocelectomy? Again, some groups say it does not improve doing a varicocele surgery, it does not improve the paternity rates. As you see in this study, this group, they had undergone the varicocele treatment during the puberty, and nearly 72 or 79% of them, they became the fathers. And in the other group, they did not undergo any treatment for the adolescent varicocele. 85% of them, they became fathers. So basically, there is no any statistical significance in the paternity rates, whether you treat or do not treat the adolescent varicoceles. Again, this group contradicts that, saying that paternity rates were slightly better in the varicocelectomy group than compared to the no intervention group. So again, like I said, data is again yes or no. EAU says that paternity and fertility outcomes are not clear. So coming to the last point, which is a failure of the testicular development. So you see this study where they have explained about the transient asynchronous growth, which is seen in adolescent varicoceles. So in this study, at the start of the study, 54% of them had a more than 15% testis volume differential. But when they did the follow-up ultrasounds for the next 2 years, 85% of them, the difference in the testicular volumes was less than 15%. So the catch-up growth can happen without even any intervention also. And the natural history of the testicular size was also studied in this paper, where they observed this adolescent varicocele kids for over a period of 2 years or for the next 3 consecutive visits. What they noted was that there was no any progression in the atrophy or the hypertrophy of the testis in the group which did not undergo any intervention for the varicocele. So again, during the clinical examination also, there could be some mimickers of varicocele, like things like Sinner syndrome, where there is a significant dilatation of the vas in the epididymis, which can simulate a venous dilatation. And when you do a Doppler on these patients, even the sperm movement can be wrongly interpreted as a reflux while doing a Doppler scan. And few things like extratesticular tubular structures like spermatocele or tubular ectasias, cavernous hemangiomas can resemble varicoceles when you're doing a clinical examination. So again, varicocele surgery, yes, theoretically can have its own complications, like hydrocele can lead to testicular atrophy if the testicular artery is injured, from hematomas, bleeding, can lead to chronic pain or even recurrence in some of the patients. So in this paper, they did a survey among the pediatric urologists, and they assessed the 2 case scenarios. The case one here is they assessed here's an asymptomatic 14-year-old boy with grade 3 varicocele, but equal sized testis. So what the survey result was that 93% of them of the pediatric urologists, they said that they would just him. And the next case scenario is a 15-year-old boy with grade 2 varicocele, but that side of the testis was smaller than the right side. And yes, majority, that is 56% said they would like to do a varicocele, but still there's a big chunk of 44% of them, they said still they would like to observe. And when it comes to what type of a varicocele surgery, the practice patterns, it used to be laparoscopic surgery in the past. Again, this data is only till 2012. So now slowly the microscopic, that inguinal approach has been increasing. And yes, so when you are doing a laparoscopic approach, the lymphatics can be preserved. If isosulfan blue scrotal injection can be given, then it usually turns, the lymphatics turn blue in color, and you might be able to preserve these lymphatics and only ligate the vein. So the Peter-Schlegel and the Goldstein group, this is from the New York, they propagate microscopic subinguinal approach. And they also say that the results are much better when compared to laparoscopic, basically lesser complications and lesser hydrocele when compared to a laparoscopic approach. I personally also do a subinguinal microscopic varicocele for all the varicocele surgeries. So the brief steps which they have described is a subinguinal incision, and then you dissect the spermatic cord, you deliver the testicle out. Again, there are groups like where I did my fellowship in Chicago, there the Professor Neideberger would never used to deliver the testis out, but would only dissect on the spermatic cord. So this Peter Schlegel and the Goldstein group, they advocate delivering the testis out so that you identify this abnormal gubernacular veins, which could be the cause of recurrence. So they propagate us to divide these vessels as well. Once you divide this, then you put the testis inside, put it inside the scrotum, and then you start opening the spermatic cord layers, which is the cremasteric external spermatic fascia and the internal spermatic fascia. And then now you need to dock the microscope with a 10 to 25x magnification, expose all the vessels, lymphatics, and the vas. And the testicular veins, you can ligate it with silk, or you can apply clips, small clips. I personally use a Prolene suture to ligate it. And yes, surgical microscope is very much essential for these varicocele surgeries. And I also use this micro Doppler basically to preserve the testicular artery, because it is very, very easy to injure a testicular artery during varicocele repair. Because most of these, when we are dissecting, the testicular arteries goes into spasm, and you don't see that classical pulsations many of the times. And it's very easy to injure this. So it's always safer that if you have the option, also use this micro Doppler when you're doing a varicocele surgery. And yes, it is rightly said that the adolescents with varicocele have rapidly changing hormone levels and may present at different stages of development. So for this reason, it may not be possible to apply a standard approach to these adolescent patients. And coming back to this case, so who had a varicocele which is palpable and also as a also has been detected on the ultrasound. So the take-home message for such a patient is, of course, yes, in the history you assess the pain, take the bowel bladder history and examination, document the size change in the testicular size between both of the testes, and then feel for the varicocele, get an ultrasound done. And yes, it is practically difficult to assess the fertility in these adolescents because doing a semen analysis is practically difficult. Start with the conservative measures, advise scrotal supports, take bowel and bladder care, like I said, timed voiding, treat constipation, and then if required, start with analgesics, amitriptyline or gabapentin. If none of this is working, and if the adolescent is really in distress, then you can, if the pain is an issue, then yes, you can try giving a spermatic cord block to see if you can break that pain cycle. And if that works, and if it gives them a significant relief, then you can decide to do a spermatic cord denervation also at the time of varicocele surgery. So these are my take-home points for all of you. And my personal approach in all adolescent varicocele, I would like to counsel them and I would like to wait. I've been trained with the best of the best microsurgeons, but still I have all the facilities. But I would like to still counsel and my approach in most of the adolescent varicoceles is wait and watch and not do a varicocelectomy in all adolescent patients. Thank you. So this is about the adolescent varicoceles. I can take up the questions and then I will move on to my next presentation, which is on the undescended testis. If there are no questions, let me see the chat box. Okay. So I don't see any questions here. So maybe I will stop this and I will move on to my next presentation. And if there are any questions about this adolescent varicocele, so then I can take up this.
There is one question which has come. Please explain how to collect sperm in adolescents for analysis.
Yeah. So it is basically by masturbation. That's why I told that it is not easy to convince such patients. It is by masturbation itself. So unless somebody knows how to masturbate, even that becomes a different problem, it's a different situation where it's difficult for us to explain how to masturbate. Yes, as again somebody has mentioned, what are the indications for surgery at present? Again, I had put up a slide in the beginning itself, and those are all the indications for surgery. But again, you can always write. There are pros and cons of each of these indications. If you see the first slide, let me share it again. Yeah, I hope you can see the slide now. So these are the indications for surgical intervention. But again, you can argue pros and cons of each of this indication. So this still continues to be a controversial topic. There are no easy answers for this, but you should know how you can argue for each of these indications. Okay, any other question? Yeah, so is there any difference in outcomes compared to adults for subinguinal inguinal lap? Yeah, so nobody has compared the pediatric versus adult varicocele surgeries because it's difficult to assess, because most adult varicocele repairs they assess in all their outcomes. They keep semen analysis as their one of the outcomes to measure outcome measures. So which is usually not possible in these adolescent groups. So, and I feel there is no any significant difference when you compare to the pediatric versus adult varicocele results as such when it comes to subinguinal or inguinal or lap. In children, like I showed, lap used to be the most preferred one, whereas in adults, microsurgical is the most preferred. But now, even for the adolescents, people are started doing microsurgical instead of lap. Okay, so I will move on to the next topic. I can also take up questions about varicocele later also, no, not an issue. So let me stop this and let me move on to the next presentation on undescended testis. Dr. Karthikeyan, are the slides visible?
Yes.
It's visible.
Okay. Yeah. So we'll move on to the undescended testis. Prepubertal phase, it is quite a straightforward case for most of you, but all the controversy again is in the post-pubertal phase, how to deal with these patients, and also I will also address the fertility as well as to some extent I will address the malignancy concerns also. So since it's for the residents, yes, all of you should be aware of what are the differences between these terminologies, retractile, ectopic, and undescended. So retractile testis is something which you can manipulate down the testis to the scrotum, and it remains there at least temporarily. And it is usually due to the overactive cremasteric reflux, and it requires an yearly follow-up till puberty because nearly 1/3 of them can ascend and become undescended testes. And then if it becomes undescended, you will have to treat it like any other undescended testis. And there is no role of any medical therapy in retractile testis. So next is the ectopic testis. So here basically the testis lies outside of its normal path of descent, and the common sites being a superficial inguinal pouch or a femoral or perineal, pubic, penile, or even a contralateral position. Again, this ectopic testis are very, very rare. And now coming on to the undescended testis, this is basically the testis is halted on its way down to the scrotum on its normal path of descent. 70% of the undescended testis are palpable, and of those that are not palpable, majority are in the intra-abdominal position. So a small case scenario where is a prepubertal 5-year-old boy with unilateral undescended testis. He has a normal opposite testis, and such a case, usually it's straightforward. You plan for an orchiopexy, depending on the where the location of the undescended testis is. So if the testis is palpable, you either do an inguinal or a scrotal orchiopexy. If it is non-palpable, you proceed with the laparoscopy, or sometimes may require a staged procedure. So yes, the child has presented late, which he has come at 5 years of age. Ideally, yes, all these undescended testes should be treated by the time they reach 18 months. That's the ideal thing, because beyond 18 months, the fertility gets affected. And a next case scenario where is a post-pubertal boy, 18-year-old boy with undescended testes. Or you can take maybe a 30-year-old guy with undescended testes, married since 2 years, no kids. He's now come to the andrologist saying for the fertility consult, you strip him and you examine and you find an undescended testis. So which we come across, not very commonly, but yes, we do come across once in a while with such presentations also in our andrology clinics. So the next step is what you need to do. Do you want to tell him that you want to do an orchiopexy, get the testis down and wait for 6 months, 1 year or 2 years so that the sperms appear and his fertility gets treated? Or do you want to scare him up saying that you're going to develop malignancy in that undescended testis, so you need to undergo an orchidectomy? Or you leave the testis alone and work him up for fertility, or maybe suggest a donor sperms and so on. So again, so this is the controversial aspect in undescended testis, that is the post-pubertal management. Yes, the AUA guidelines, the last updated was in 2018. So what it says is, you do an orchidectomy when there is a short testicular vessels, or when there is a short vas difference, or in a dysmorphic testis, or all patients who present to you in post-pubertal age who have a normal contralateral testicectomy. Again, this is a clinical principle. The level of evidence is very weak, and this is just a clinical principle without any a good recommendation. So what happens if not treated before the puberty? Yes, it can affect the reproductive function and also can increase the risk of malignancy. So let's discuss about these two things. So normally, there is a disappearance of the fetal stem cell pool and appearance of the adult stem cell pool. This transformation usually starts at the age of 2 to 3 months of age, and is usually normally complete by 6 months. And this is the first major step in the maturation of the hypothalamic pituitary testicular axis, which is usually a consequence of the transient surge in the hormones, which are FSH, LH, and the testosterone. And also in this so-called mini puberty, the spermatogenesis is regulated by nearly 2000 genes. So this is a normal phenomenon which should happen in all. But what happens in undescended testis is there is a delay or ineffective transformation of this fetal stem cell pool to the adult stem cell pool. And there is a failure of this hormonal surge and also some genetic mutations. And also this inguinal heat stress can generate reactive oxygen species. And also these undescended testes are known to have an impaired testicular size compared to the contralateral testes. And when you're dealing with a bilateral undescended testis, when you have been called to see a newborn who has been newborn who has a male phallus, but both gonads are not palpable, and potentially all this have to be considered as a congenital adrenal hyperplasia until proven otherwise. So usually the initial step, which is checking the serum electrolytes, is all taken care by the pediatricians or the neonatologists. What we need to remember is to do a karyotyping in all bilateral undescended testis patients, which we usually also follow in our hospital as well. So is there any role for imaging? The ultrasound, the sensitivity is less in localizing a non-palpable testis, and the ultrasound, doing an ultrasound will not change the management plan. Is MRI useful? The accuracy rate of MRI in a non-palpable undescended testis is around 42 to 88%. But the important point here is that the false negative rates are up to 38%. So in spite of spending so much, still the false negative rates are up to 38%. So what the guidelines say that you don't have to do any imaging in a patient with undescended testis. So when the testis is palpable, you proceed directly with the surgery, either inguinal or the scrotal orchiopexy. If it is a non-palpable, you do a diagnostic lab and then take it forward. There is no need for doing a imaging. This is what all the guidelines say, but practically I feel most of us ask for a simple ultrasound at least. You never know if this turns out to be a medical legal case or something. Even without any imaging, you do a surgery, and if something goes wrong, you might end up with trouble. So yes, in the exam, you will not be told wrong if you say imaging is not required. But for all practical purposes, I think most of us, we ask for an ultrasound scrotal. So is there any role for hormonal treatment? There is no consensus on this, but EAU says that endocrine treatment may be useful in bilateral undescended testis. Again, this is a weak recommendation. The hormonal therapy that you are giving is not for the testicular descent. It is to preserve the fertility potential in a bilateral undescended testis. Again, this is still controversial, and the level of evidence is 4, which is very weak. HCG treatment is harmful, and what is recommended is the GnRH analogs, which are given for usually 4 weeks. The success rates are very, very variable, as low as 9% and can be up to even 60%. But again, this is still controversial. I do not have any experience with the hormonal therapy, and we do not follow it on our center as well. We do not follow. AUA also says that it should not be used, hormonal therapy should not be used. And since there are no long-term studies on the fertility with the use of hormonal therapy, again, it is not recommended. So in short, no role of hormonal therapy at present. Yeah. So if you have a palpable testis, like I said, you proceed with orchiopexy, inguinal or scrotum, whether the testis is at the inguinal region or in the suprascrotal region. And few operative steps about the inguinal orchiopexy. You mobilize the testis spermatic cord till the internal inguinal ring, and you dissect and divide all the cremasteric fibers in and around to prevent the secondary retraction, and also detach the gubernaculum testis. Ligate the patent processus vaginalis proximally at the inguinal ring to prevent again the retraction. And also, if you feel that you're still unable to bring down the testis to the scrotum, you can do a Prentice maneuver, which is again a very commonly asked question in some of the viva. So you basically divide the inferior epigastric vessels medially so that you can transpose the spermatic cord medially, so that you get that extra length to bring out that testis directly to the scrotum. And yes, you use the sutures you fix it between the tunica vaginalis of the testis and the dartos muscle of the scrotal wall. And when it comes to non-palpable testis, So you, under anesthesia, you need to again re-examine. Sometimes these non-palpable testes may become palpable. If they become palpable, then you can proceed with the inguinal or a scrotal orchiopexy. If it is still not palpable, you basically do a diagnostic lab. And during the diagnostic lab, if the testis is close to the internal ring, you complete laparoscopically, or you can sometimes even be able to do an inguinal orchiopexy as well. If the testis is too high, that is, if the testis is lying more than 2 centimeters above the internal inguinal ring, and in this case, the testis may not reach the scrotum without the division of the testicular vessels. In such a case, you might have to do a staged Fowler-Stephens procedure. If you see a blind ending spermatic vessel, then it is usually a vanishing testis. You just basically stop the surgery at that moment. And then if you feel that the spermatic vessels are entering the inguinal ring, then you can stop the laparoscopy part, and then you can do an inguinal exploration as well. So what is this two-stage Fowler-Stephens orchiopexy? Is basically since there is inadequate length, you divide the main vessels that are supplying to the testicular vessels basically, and then you give 6 months time for this testis to develop the collaterals. So when you divide, the testis is based on the supply from the basal artery and also the cremasteric artery. And over a period of 6 months, it develops collaterals, and that is when you will be able to mobilize it even further into the scrotum. So that's a staged Fowler-Stephens orchiopexy. And yes, the first stage in that is laparoscopic. The second stage can be a laparoscopic, or it can be an open. And the success rates range from 75 to nearly 100% in some of the series. So let's move on to the fertility and the malignancy aspects when you're dealing with an undescended testis. So the azoospermia in general population, it is around 0.5%. In bilateral undescended testis in untreated cases, it is more than 90%. In some papers, it is even 100%. Whereas in treated bilateral undescended testis, treated means they would have undergone orchiopexy and so on. So in such cases also still there is a 42% chance of azoospermia. In unilateral undescended testis, it is 13% whether it is treated or untreated. And we should be aware of these terminologies. What is a fertility rate and what is a paternity rate? So fertility rate, in simple terms, to say it is how many children, what is the capacity of that particular individual to make, basically saying that how many children can he make? So that's the fertility rate. Paternity rate is, can he become a father? Whether it's a 1 child, 2, 3, it doesn't matter, but can he father a child? So that's the paternity. So in unilateral undescended testis, there is a lower fertility rate, which meaning that making more babies is difficult, maybe lesser, but the paternity rates remain normal. Whereas in bilateral undescended testis, both the fertility and paternity rates are lower. So if you take this, one of these landmarks paper, so when they followed up this cryptorchidism patients, what they noted was that the paternity rates in bilateral undescended testis patients was 61%. In unilateral undescended testis patients was nearly 89%. And in the control, which is a normal population, that was 93%. So as you see here, the paternity rates in the unilateral undescended testis is nearly comparable to the general population, whereas it is significantly less in the bilateral undescended testis. This is about the paternity. So moving on to the last aspect, which is about the malignancy. Again, this Swedish study is the only quoted study in most of the presentations or even in the textbook about dealing with malignancy and with relation to undescended testis. So what they have noted in this landmark study is that when the age of orchiopexy is beyond 13 years, the hazard ratio becomes significantly higher. So the relative risk of a testicular cancer compared to the Swedish general population among those who underwent orchiopexy in the subgroup less than 13 years, it was 2.2, whereas in the more than 13 years age group, the relative risk was 5.4. So which is quite high and quite significant. And the type of tumor you see that develops in an uncorrected undescended testis is seminoma, whereas in corrected undescended testis is usually a non-seminoma. And yes, the AUA, like I said before, says that in a post-pubertal age, you need to do an orchidectomy if the contralateral testis is normal. EAU also gives recommendation in the same terms, but again, you can see that it is still a weak recommendation and level of evidence is still lower. And if you come across this nice article where they have answered some of the important points. So if you see the fourth question, does orchiopexy decrease the risk of testicular cancer? What they have told here is that the orchidectomy should be discussed with all post-pubertal men up to the 50 years of age. Beyond 50 years, the risk of testicular cancer is undefined. And another aspect that I have addressed is there any risk in those nubbins which we occasionally feel during the palpation? Again, what they have told is that the malignant degeneration in these small nubbins which we feel is very minimal. In fact, till 2009, the time when this paper was published, there was only single case of a carcinoma in situ that was reported. So again, this is again an important landmark paper. So in this undescended testis, there are 4 landmark papers which are very commonly presented in all the conferences and also in most of the publications. So here, what interesting finding was that this is basically in Turkey for the military recruitment, those with undescended testis, they had to undergo an orchidectomy because of the risk of malignancy. So 51 such men in the age group of 20 to 24 years of age, they underwent unilateral orchidectomy who had inguinal undescended testis, but with normal contralateral testis. The interesting findings were that of 26 out of the 51 men, that is 51% of these patients had some germ cells at different maturation levels, which means there were some sperms even in this undescended testis, which is again a fertility potential is still there. So if there is any infertility issue after he gets married, these sperms could have mattered or could have been used with the current advanced ART techniques. And the malignancy, they noted just one case of malignancy in that 51 patients, which contributes to around 2%. So it's time we need to think that whether is it okay to sacrifice all these undescended testes when they're present in the post-pubertal age, or do we give them that fertility chance in case if they go through the infertility phase after they get married? So this is a balance that we need to make and counsel the patients accordingly. So the take-home message in undescended testis is see whether it is palpable or non-palpable. Things become quite easy if it is palpable. And imaging is not mandatory. In the prepubertal, yes, orchiopexy is best advised. The optimal time is by the time the child reaches 18 months. In the post-pubertal phase, especially when somebody coming in his adulthood, so if the testis is palpable, you can give them the option of the close follow, teach them self-examination of the testis so that they pick up if there's any abnormal testicular findings, and also counsel them about the malignancy. That's the reason why they need self-examination. If it is a non-palpable undescended testis in a post-pubertal age, since we cannot highly depend on, because it's quite difficult to follow up this non-palpable testis, so it's better to offer them orchidectomy. And of course, all patients of undescended testis, we need to always counsel about the fertility and malignancy aspects. And most important, even after you do an orchiopexy or whatever surgery on them, you should teach them self-examination, because the risk of testicular cancer is higher when compared to the general population, the risk is higher even in this corrected or treated undescended testes. So I would like to conclude this.
Thank you, Pramod. I think one or two questions are there. You can answer in chat box, but because we have to finish two more presentations, I think it's better to invite Karthikeyan to begin with his presentation.
Sure, sir.
Sir. Thank you, sir. Thank you for the opportunity. So what I have done is I have taken up the two topics in a single presentation. So we will deal with from semen analysis to evaluation and then the management of obstructive azoospermia, sir. So to directly start with, so how do we approach a patient of infertility? So here, what we have to see here is we have to understand that infertility is a couple evaluation. So whenever we base our treatments, it should be based on the female partner as well and the duration of infertility. So these two things are important when we make a decision. And we have to also learn to interpret the WHO semen analysis, maybe the 5th edition which has been used, or maybe the 6th edition which has come recently. Then we have to understand how do we evaluate a patient of azoospermia and also the low sperm counts. And then we will go on to learn some management about obstructive azoospermia. So the management of non-obstructive azoospermia is simple. So it just only sperm retrieval. When an obstructive azoospermia, we have some more role, which may be either a reconstruction of the vas-vasal epidermal blocks, or it may be a cyst in the ejaculatory duct. So these will be the main points which we are going to discuss in this presentation. So what is the definition for infertility? So it is inability to conceive even after 1 year of regular unprotected intercourse. So it involves evaluating both male and the female. So what are the female partner factors which we have to see? So age of the partner, the ovarian reserve, the tubal patency, the general health, and the comorbidities. So these are the main things. Then the duration of infertility, and then the male factors. So as the age of the wife goes beyond 30 or 35 in that matter, or if the ovarian reserve is coming down, then these are the things where we have a more conservative approach to the male because they may eventually require a ART. So ART may be either IUI or a test tube baby, that is IVF or ICSI. So that is the basic. Next is the tubal patency. So whenever there is a condition, maybe a severe thing like an endometriosis or there is a tuberculosis in the female, then again we have to keep our minds open towards ART. If the general health and comorbidities are also there, based on these factors, we tailor our treatment for the male factor. So coming to what we have to understand about semen analysis. So the basic thing is to understand what is the difference between the WHO 2010 and the WHO 2020. So there are some changes. We have to note that this has been done based on the men who had children in the past 1 year. So that is the basis of the data. So from that, from across 6 continents, it has been tabulated, and that is how the 2010 reference values were given and they were plotted, and the 5th percentile is what we use for the so that is the 5th percentile which we use for our interpretation. So here the first important thing will be what is the abstinence period.
Background noise is there, some background.
Please mute all of them other than the presenter.
Yes.
Go ahead, Karthik.
Yes, sir. So the abstinence period is the most important thing. So standard of 2 to 5 days, even though it is mentioned as 2 to 7 days, 2 to 5 days is okay. We have to see the macroscopic and the microscopic characteristics. So we see the semen volume, the concentration, then a multiple. So the total number of sperms in the ejaculate, progressive motility, and normal forms. So these are the main things. So in the WHO 2010, it was 1.5 ml, 15 million, 32% progressive motility, and 4% normal forms, which has changed slightly in the newer edition. And the other things which we have to note here is a minimum of 2 to 3 analysis should be done at 2 to 3 weeks apart because of various factors which can alter the semen reports. And abstinence is 2 to 5 days. And for assessing the bulk seminal parameters, that is the motility, etc., actually a 1-day abstinence is the best. And semen pH is no longer considered important. So the main thing when the semen pH is important is to differentiate between obstructive and non-obstructive azoospermia. And a macular chamber is best used for counting. Even a Newburst chamber is also good enough. So at the end of the semen analysis, what we have to understand is what is the definition for oligospermia, that is less than 16 million per ml, the latest guideline. Severe oligospermia is less than 5 million per ml. Asthenospermia is less than 30% progressive, which is more important. The teratospermia is less than 4%. And pyospermia is more than 1 million per ml, that is 10 power 5 pascals per hyperfill. Some reports contain this value and some, so both of this we have to know. Why this is important? The one more point which we have to note in pyospermia is leukocytes and immature sperm cells are not differentiable. So whatever the lab is reporting should be pus cells. So only then this is significant. So whenever a question is asked about semen analysis, these are the main things which we can write in the answer. And very importantly, this is the basis of the further workup which we do for our patients. So the evaluation for whatever azoospermia, low sperm count, everything is the same. So we have to understand about the hypothalamo-pituitary gonadal axis. So very simple. So the hypothalamus, GnRH, it stimulates the anterior pituitary, FSH and LH. So LH acts on the Leydig cells and stimulates testosterone production. And the FSH acts on the Sertoli cells and causes spermatogenesis. And we have to also understand that this testosterone in the intratesticular level is again very important for spermatogenesis. So whenever there is low testosterone, it can lead to impaired spermatogenesis. And prolactin can actually inhibit the GnRH and therefore cause problems. So whenever we have a patient of low sperm count or azoospermia, we see what is the status of the HPG axis. And whenever patients have taken medications like clomiphene citrate, this HPG axis is also altered. Whenever there is obesity, again, one more thing which is not mentioned here is the testosterone getting peripherally converted to estradiol because of the aromatase. So these are the 4 main hormones which we use. Other than the FSLH testosterone, we also add estradiol. In some patients, we use prolactin. So these are the 4+1 hormones which we use for the evaluation of any patient who comes with either low sperm count or azoospermia. So going on, whenever there is a low count, we then see the volume of the semen sample. So if the quantity is low, then we have to ask further questions like whether it was an improper sample, that is whether it was very difficult to collect the sample, or was there any spillage, or whether the patient knew to collect the sample, or whether it is the first time the patient is collecting a sample for analysis. Specifically in azoospermia, whenever we see azoospermia, we have to do repeat sampling before confirmation, confirming all these things. So we repeatedly see some men giving only 0.5 or 0.7 ml and it comes as azoospermia. But after adequate counseling, we see patients giving a good sample and the counts may be even normal. Even yesterday we had a patient like that. So sometimes the men may give a urine sample. So all these things come into the picture when we give a sample for, when we interpret a report as azoospermia. So the next thing is why we have cutoffs. So what is oligospermia? Why severe oligospermia? That is to tailor our investigations. So when a man requires endocrine evaluation, whenever the sperm concentration is less than 10 million per ml, or there is a history of sexual dysfunction, or when we examine the patient may have, say, diabetes mellitus, obesity, etc. And whenever the sperm concentration is less than 5 million per ml, we also do genetic evaluation. However, there are many centers which practice only for azoospermia, they do the genetic evaluation after diagnosing the type, whether it is obstructive or non-obstructive. But of late, we are now doing even for less than 1 million. And for azoospermia, we are doing genetic evaluation. Or in specific situations, we are doing the genetic evaluation. So further, the sperm DNA integrity assays, that is what even Dr. Pramod mentioned in his presentation about the adolescent varicocele, the sperm function tests and the advanced sperm DNA integrity assays. We have the sperm DNA fragmentation index and the sperm reactive oxygen species. So these are two more things which may be like they are upcoming in the evaluation of infertility, specifically idiopathic infertility, when we are not able to find a cause. The testicular size is okay, the FSH is normal, the sperm production is okay, but motility and the morphology is not good. And we have pustules in the semen, but there is no infection, there is no epidermal tenderness, etc., which can point towards a reactive oxygen species, and in some situations also the elevated DFA. So these are the newer things which we can also include in the semen analysis. And the WHO 6th edition actually adds these two things. The addition of DFI has come in the 6th edition as a pointer. So going on to how do we evaluate a case of azoospermia with this background knowledge? So the first thing, repeat the sample before confirmation. History. So whether the sample has always been low, how was your ejaculate, especially if we have a low volume ejaculate. Physical examination, specifically to look for the bilateral vas and the testicular size. So these are the two main things. Semen analysis, as I told, at least 2 samples or 3 samples, and then genetics will be done. So this image is like a representative image. This shows this into mark is the place of spermatogenesis. So this is just given here because we have to understand that in obstructive azoospermia, the production is normal. So even in a normal person, there is uniform or homogeneous spermatogenesis, while in non-obstructive, there is reduced sperm production and there is heterogeneous sperm production. So we don't know at what place of the testis there is sperm production. So this forms the major background for the treatment of azoospermia. So what technique we are going to do? All the evolution of surgical sperm retrieval, all of this is based on the heterogeneous or homogeneous spermatogenesis. So if we understand this concept, then going into the treatment is simple. So here there is patchy spermatogenesis. So if we put in a needle, sometimes we may hit a place where there is no sperm production, and we can falsely tell that this patient has no spermatogenesis. But in obstructive azoospermia, usually a needle can hit the sperm bearing area, and in almost 95 to 97%, we will be successful. So this is a table which shows the major differences between non-obstructive and obstructive azoospermia. In non-obstructive azoospermia, on the physical examination and the testicular examination, there may be features of hypoandrogenism. Example, say a Klinefelter or obesity, a low testosterone, all these things can be there. So abdominal obesity, visceral obesity, a tall and like whatever the Klinefelter syndrome, etc. These are the things which we can see in a non-obstructive azoospermia. Where in an obstructive azoospermia, usually the testis volume is normal and the man is otherwise looking normal because there is only an obstruction, but the testosterone is also usually normal. The vast difference in non-obstructive azoospermia, by definition, it is present. In obstructive azoospermia, it may be present or absent. If it is absent, it signifies congenital bilateral absent vas difference if it is on bilateral. And if it is unilateral, say a CUAVD, it can be due to anything. And there are some situations when both the vas are present, and since we take it as obstructive azoospermia, where the obstruction is at a more proximal level, there comes the role of further evaluation and then the treatment. Semen volume again in non-obstructive azoospermia is usually normal. In obstructive azoospermia, if it is a CPAVD, then it will be around say 0.5 ml or 0.6 ml. But in other cases, it is usually normal. The FSH again in non-obstructive azoospermia, it can be both ways, normal or abnormal. But by definition, in obstructive azoospermia, the testis volume is normal and the FSH is normal, testosterone is normal. So this is the basis on which we differentiate between non-obstructive and obstructive. So for that, the testicular size will be taken on either a Prader's orchidometer, where it will be around 15 to 25 ml. That is the normal size, or the longitudinal axis is more than 4.3 centimeter. So this is the cutoff. All these things are important to guide our genetic evaluation towards non-obstructive or obstructive. So the gamut changes when we divert into obstructive or a non-obstructive azoospermia. So this again a clinical algorithm. So whenever we have azoospermia, if there is a bilateral vas absence, then simple we do a CFTR and we proceed in that direction. If the bilateral vas is present, then if it is less than 1 ml, then we have to also rule out retrograde ejaculation. But then in young men, usually we have a history, there is no diabetes. All these things, the retrograde ejaculation part comes lower down in the list. So if the semen volume is low and the parameters are good, so that is the transverse length of the testis is more than 4.6 and the FSH is less than 7.6, most likely it is obstructive. And whenever it is opposite, then most likely it is spermatogenic dysfunction. And whenever there is a low volume, if the vas is present, then if the retrograde is also ruled out, then we also can do a truss after ejaculation. The same day we do a ejaculation, ask the patient to do ejaculation and immediately do a truss. That is to false positively, sometimes the seminal vesicles may be dilated. So that is how we proceed with the patient of azoospermia, whether it is obstructive or non-obstructive. So after this, we have a fair idea. Now a bit about the non-obstructive before we go into the obstructive, because this is very important. So we saw azoospermia. We thought, and we after the evaluation, we diagnosed it as a case of non-obstructive azoospermia, and we did the hormones. So there may be three situations. So one is a hypergonadotrophic hypogonadism, one is a hypo, and then is a eugonadotrophic. So here the basic difference is, in this we have a primary testicular pharia where the LH and the FSH are high. So again to note, as we said, the FSH should be less than 7.6. So when it is less than 7.6 cutoff, it usually denotes a normal spermatogenesis or the spermatogenesis is intact. When the FSH is going up, it means that there is a problem at the testicular level. If the FSH is very low, LH is also very low, then it means the testis is probably okay, but there is a loss of signal from the above, maybe hypothalamus or the pituitary. In eugonadotrophic, it is very difficult, but it can simply state that the testis is still, it can respond to the stimulation. So the entire picture changes. Here, the causes are different. Here, actually, we have a role of the therapy with HCG and HMG. And here we go again by genetics. So here it is genetics, here it is genetics. Here maybe a role of HCG followed by HMG is required. Going into obstructive azoospermia, it can be an absent sperm passage, that is the CBAVD, or a block in the sperm passage, which may be due to block in the tubes or infection, post-vasectomy, ejaculatory duct obstruction, and post-op status like a hernioplasty where the vas was caught in the mesh, something like that. So this is the role where we have a role for surgical correction. Here we don't have a role for surgical correction. So genetics in non-obstructive azoospermia, it is the karyotyping, YQ microdeletion, and off late the genomic fertility analysis. As again Dr. Pramod mentioned, more than 2000 genes are involved. So in spermatogenesis specifically, at least they new panels, they detect at least, they look for 300 or 400 genetic mutations. So nowadays in non-obstructive azoospermia with the newer panels, we are getting a causative reason in each of the case which we have sent for non-obstructive azoospermia. In obstructive azoospermia, if it is CBAVD, then the CFTR is the most important gene mutation. So in CBAVD, there is no surgical option. So when to do a vasoepidymostomy or a vasovasostomy? More often, this is used when there is a post-vasectomy, when there is a need to do a vas reversal. The vasoepidymostomy actually comes into the picture when we have a case of all the sperm is azoospermia, the FSH is normal, the testicular size and testosterone are normal, otherwise the patient is okay. So at that time, we then go in to see if there is a microtubule obstruction or there is a very proximal obstruction. At that time, we can actually do a vasoepidymostomy. So for that, we actually see what is the characteristic of the vasal fluid. If it is copious and watery, and if the condition is also post vasectomy, better, then that is the main situation where a vasovasostomy is coming into the picture. If a scant and thick fluid is there, usually we go for a vasoepithelial anastomosis. So there is no actual mechanism to identify if there is an obstruction at this level. So whenever the parameters, that is the FSH, the testosterone and the testicular size fit into the criteria, then we can do this procedure and we can go ahead with the VEA, which is more like an empirical treatment. So vasography, the absolute indications nowadays not routinely practiced. The absolute indications are at least one vas is filled. So that means it's an obstruction. So we can, at least the biopsy shows spermatogenesis with azoospermia and one vas present. That is an absolute indication for a vasography. Testicular biopsy only when the axis, that is the total length, longitudinal length is more than 4.6, normal FSH. negative anti-sperm antibody, then a testicular biopsy comes into the picture. If you are contemplating on a, say, surgical management. Otherwise, nowadays, there is no diagnostic testicular biopsy and the vasography is not routinely done preoperatively. So vasovasostomy, the intersusception technique, it is the live that is more commonly performed. And vasovasostomy, more often, see here in vasovasostomy, the advantage is that this patient has already had a successful pregnancy most of the times. Therefore, there is more likelihood that if we establish a passage, then there is again possibility that he can have a normal pregnancy. So here the important points to note are a mucosa to mucosa approximation done at a high magnification. A leak-proof anastomosis is important because the integrity depends only upon the sutures and there are no platelets in the epidermal fluid. It should be tension-free, blood supply should be preserved, and a atraumatic anastomotic technique with the 9-0 monofilament nylon. So these are the main points to be noted in a vasovasostomy. The main point, the why we go in for a surgical correction of VEA or VVA, because it gives more possibility to have a pregnancy. Whenever we go for ART, we tend to move towards ART. Even in the US, the present considerations is like that. This is a more cost-effective approach when compared to ART. That is one thing. And second thing is, if we do the surgery, maybe it takes time for the sperms to appear in the ejaculate. But then once it has appeared in the ejaculate, then the couple have a chance to conceive in every cycle of the menstrual cycle. While in ART, in IUI or IVF, the number of chances get limited. So even when all the parameters are okay, the maximum success rate for an IVF cycle is around, say, 60 to 70%. So there are multiple factors. So this actually is coming back. So the vessel reconstruction or microsurgical reconstruction is coming back into the picture after the era of IVF, because one, the finances are getting exhausted. Second thing is, this is a more cost-effective approach. And in the long run, the pregnancy rates can improve when the sperm starts appearing in the ejaculate. So this is the important thing to be learned about microsurgical reconstruction of the vas and the vasal epidermal or vasovasal anastomosis. So one more thing is ejaculatory obstruction. This is seen in around 1 to 5% of infertile men. So when do we consider a diagnosis of EDU? So the classical thing which is given is a man presenting with peri-ejaculatory pain, a low volume ejaculate, or a hematospermia. So these are the conditions where we think about EDO. That is one thing. And second thing is when there is a constantly low volume ejaculate, or sometimes the counts are okay, but then the motility is not very good. There is no varicocele, FSH is normal. Then at that time also we look for some obstructive causes like EDO or a partial EDO, whatever. So this is the specific situation where we have a consideration towards the ejaculatory obstruction. So we use the TRUS probe to identify whether there is enlarged seminal vesicle or the ejaculatory diameter. So here the point to be noted is fertile man can at times have normally dilated seminal vesicles during sexual abstinence. So the best way to do it is to do the same sperm semen analysis on the same day or the next day. We can do a TRUS. Sometimes an MRI is also used, but most often a well-done TRUS scan, specifically if we are trained to do it, then that will be the best way to pick up these things, and we can have a confirmation specifically when MRI is necessary. So in EDO, we have multiple cysts. Here the utricular and Mullerian cysts are actually midline. So the thing is, a paramedian cyst is more often it will contain a sperm, and that is the Wolffian duct cyst. So this is paramedian and located posterior to the prostatic urethra, even though it is less common. And also the other things which we off late, these things are coming into the picture: seminal vesicular calculi, inflammation and scarring. So these are the things. There are some men who have undergone, say, BNI or TORP, but the one thing from this slide we can learn is a Wolffian duct cyst and a seminal vesicle calculi. There may be some inspissated material blocking the duct. These are the things which we can pick up and try to clear them so that the spermatogenesis, that is the sperm, starts coming into the semen. So a turret may be sometimes assisted by laser, or an antigrade SV lavage. That is what I said. So into the Veru, we go inside the Veru and identify the ED, and then go into that. We clear the material or the calculus sometimes, and that can be done with the seminal vesiculoscope or a 9 French or even a ureteroscope for that matter. So these are the specific surgical options which we can offer to patients. And for this, we need a high index of suspicion, a good imaging, and corroborating all the findings. So the surgical sperm retrieval. So here there may be a epididymal or a testicular. So epididymal more often in obstructive, specifically in CBAVD. If the epidermis is not well formed, we go to the testis. In other forms, like what I told, the microtuchal obstruction, the epidermis, if it is full, so whenever we clinically palpate, if the epidermis is full, at that time, actually epidermal sperm is better because it has a better motility. So even when we do a TISA, even though the sperm in the testis is immotile, sometimes the embryologist says that there are motile sperms from the testis, and they also use some agents like pentoxyphylline to improve the motility, and they consider that the motile sperm is the better sperm. So even though we know that in the testicular sperm, actually the motility is very less. So the advantages of a PISA is it is very minimally invasive, and we use a very minute needle. So therefore, the damage to whatever epidermis is very less. In microsurgical epidermal sperm aspiration, even though it requires microscopic assistance, it can be a very good procedure whenever there is an obstructive thing. In non-obstructive, as I showed again to remember the diagram which we had a schematic diagram. So whenever the FSH levels keep going up, it means that the heterogeneity in spermatogenesis is going up. So lower FSH, even in a non-obstructive azoospermia, we can get away with a TISA. But as the FSH goes up, as the testicular size starts coming down, we need more and more advanced techniques like a multiple sites of multiple quadrants, or the SSST technique, or then the micro TC. So this is the gradation in which we do our procedure. So we plan for a TISA bar micro TC. If we get sperms on TISA, it's well and good. Otherwise, we go for a micro TC. So in obstructive azoospermia, epidermal sperms, whenever the epidermis is well developed and the epidermis is turgid. Whenever there is a non-obstructive azoospermia in a low FSH, or even for that matter, a FSH of 15, if we don't get by needle, then we go for a micro TC. As the FSH is lower, even if we don't get on TISA, sometimes the micro TC can give a better success. And these, whether we will get sperms, all those things are also guided by the genetic tests. So this is the basic difference. So this is a dilated tubule which will be seen on a operating microscope. So we tease this tissue specifically. That is the area where a sperm is produced, and we examine it under the light microscope, which is in the OR. So those tubules are specifically taken for sperms, and the excess tubules are preserved. So next thing will be a varicocele with azoospermia. It is very difficult to say whether the varicocele has caused a azoospermia. So here, the one or two things which we have to remember is, what is the testicular size? What is the FSH? What is the genetic evaluation of that man? So if there is a genetic problem, then probably varicocele is an association with the azoospermia rather than varicocele causing the azoospermia. In 10% of the patients, a varicocele repair can cause sperms to appear in the ejaculate. The favorable factors. When do we offer varicocelectomy for these patients is a large varicocele, reasonable size testis, a reasonable FSH. And if we have seen at least hypospermatogenesis on biopsy, then it is okay to recommend a varicocele repair, but with full explanation that it may not be a useful procedure and all those things. So varicocele repair for a palpable varicocele is recommended with ASRM in all the situations except for azoospermia. In azoospermia, we do varicocele repair only after a careful evaluation and a careful counseling, plus minus genetic evaluation based on the case. So this is how we decide about the role of varicocele in azoospermia. Thank you.
A white box, Karthik, just hold on. There are a few questions from, I think Pramod has
answered a few of them.
Answered all the questions related to.
Surendra, Karthik, there is a question from Surendra Reddy. After how many weeks of VEA we can order semen analysis?
So usually it is after 3 to 6 months, but sometimes the sperm start coming even after 9 months. So even if we have a negative report, we can keep repeating it before we declare it as a failure. We can repeat it at least say up to 6 months, 9 months, or even 1 year.
Dr. Anant Kamath is asking, what about fructose test in ejaculatory duct obstruction?
So fructose test is nowadays not routinely used. We rely upon the volume, the pH, and even if the fructose is absent, it doesn't actually, we cannot base our findings only based on a fructose test, sir. It may be positive or negative. Pramod, so anything to add regarding fructose?
But if he has got a low volume, with the fructose being negative, it would point more towards ejaculatory duct obstruction.
More towards, yes, sir. That is yes, sir. More towards an obstruction. That is okay.
In our, Dr. Keshav, in our lab, they don't do fructose at all.
So yes, sir. Even in my fellowship in Chicago also, it's an academic university, so they never used to do a fructose test because it's of the classical old teaching of fructose positive, it is normal, fructose negative, it is obstructive. That is no more held good now, sir. We don't rely at all on fructose test nowadays.
No, you don't rely on that, but it is a good indicator to suggest that if he's got a low volume, along with the fructose being negative, it would suggest an obstruction.
Yeah, but we have seen obstructive cases even with positive fructose levels, sir.
Pramod, but one thing, if you request, they will do. Supposing you have a suspicion, you want to corroborate that I am very sure, means like labs will do the fructose also.
Because there are some labs, even today, if you don't write, if you're sending a patient of azoospermia for a testicular biopsy, needle aspiration biopsy, they will ask, where is the fructose? Is it fructose positive, fructose negative?
Absolutely.
The one more problem here actually, sir, whenever there is a low volume ejaculate, sometimes the labs do not know to actually tailor their fructose. So they tell that in 0.5 ml, we are not able to do the test. That point also comes into the.
Yeah, that is also true. That's also true.
Sir.
Correct. That is when you ask them to do and they will say it's difficult to do with this volume. That's absolutely true. Absolutely.
Specifically in this situation only we want, but in that situation, then we have to train our people to do that. Yes, sir.
Yeah. Well, just let me just see. Yeah, that was, I think, all from the last question was from.
But Pramod, doing semen analysis using one of the Mackler's chambers or Newber's chambers, how is it? Is CASA better than that?
So no, sir, computerized tests are very much inferior to the manual ones. So in fact, if any comes with a computerized report, I always tell them get a report from any fertility center which is manually reported by an embryologist using these old chambers. CASA is no way better than the manually reported ones. Sir.
But actually, Newber's chambers are not to be used for semen analysis.
No, but they are used for that, sir. Very commonly used. But because even any small artifacts also it picks up as sperms in that computerized semen analysis test.
Actually, the Mackler chamber is more costlier one, so not every place is able to afford it. But then the way we count and other things remain same, sir, in the Macklers and the Newber's. So it is okay to use a Newber's chamber and standardize our results. That is acceptable.
So you would recommend not to buy a CASA?
Yes, sir. Especially in our, like whenever they come with infertility, the reports are so contradictory. As Pramod told, the main thing what we rely upon is the embryologist who reports the report. And most of the times it is opposite to the CASA report.
That's correct. So with no more questions, I think I thank Dr. Pramod and Dr. Karthikeyan. I think residents would have got a lot of benefit in their preparation to exam. that was little, what you can say, the focused andrology for you people, and the important topics covered. I think if you see the presentation which Pramod had, a lot of evidence to support different controversial issues he has put, that will be very useful. And Karthikeyan has a very difficult topic. He has made it so simple with his crisp presentation. I think if somebody has concentrated on the flow charts, I think if you go back to the recorded, which is there, a presentation, the YouTube, you can just go back again and look at the videos. With a nice flowchart, he has finished the schema analysis as well as the management of objective as per me, as well as the this evaluation management both. I think thanks on behalf of Indian School of Urology and USI to both of you. Topic well covered, very useful. I think time well spent, I think, for all the residents. With this, I hand over to Dr. Keshav for his closing remarks, and then we'll call it a day. Dr. Keshav.
Thank you, Arun. Thank you, Dr. Karthikeyan and Dr. Pramod, for your time for this program. It was wonderful. I've sat through the whole program, and I hope the residents have benefited with this. They would be benefited when they face the exam. These questions would be asked to them. So thank you very much, Pramod and Karthikeyan, for your time.
Thank you, sir.
Thank you, sir. Thank you. Thank you very much for the opportunity.
Thank you, everybody. Thank you. Good night.
Thank you.